All to this Wednesday session. Today, actually, the topic is pancreatic pathologies. As we all know, the identification of pancreatic pathologies as well as characterization, diagnosis, all are a little complex because I think the most important part is actually the identification. Sometimes the lesions may be too small to be seen now. So the more you see number of cases, the more you hear from the experts, the pancreatic pathologists and all, I think the more well-versed you are with the pancreatic pathologists, and also you are more comfortable when you present the exam. Today, it is going to be presented by Dr. Reshmi. I welcome Dr. Reshmi for this session, and also the coordinator, Dr. Sunimol. And then I welcome the backbones of IRIA Kerala chapter, President Dr. Gomadi Madam, Secretary Dr. Rijo Matthew, and convener Dr. Ramesh and I welcome once again all of you to this session. And now over to Dr. Gomadi Madam for opening remarks.
Okay. Thank you, Dr. Venu. I'm very happy to have Venu as our chairman because he's very punctual for all the teaching session which we have started from January. And I was very happy when I went for the IRI conference. I could see that most of the faculties were approaching me because they wanted to give us talk for Kerala IRI. So I was very happy because I was seeing that most of the faculties are attending our sessions, and residents are very happy to have a session. So I think this Kerala IRI teaching session will have a star by the end of the year. So we are ending with our hepatobiliary pathologies, including pancreas this month, and we'll be starting with a new chapter by next month, April. So I welcome all the residents to hear the PG discussion with Dr. Reshmi. Thank you. Over to you, Suni.
Yes, ma'am. Good evening, all. My role is to introduce today's faculty, Dr. Reshmi, my friend. I'm very happy to welcome her and conduct a session for my PGs from KIMS Trivandrum. Dr. Shilpa, Shravya, and Dr. Sukanya are participating. Dr. Reshmi's CV is full of academic excellence and gold medals from her school days. Dr. Reshmi, is there a disturbance? Okay. Dr. Reshmi did her MBBS and DMRD from Government Medical College, Trivandrum, and she was receiving the gold medals from first year to the final year of MBBS. She did DNB radiology from RCC, Regional Cancer Center, Trivandrum, secured first rank and gold medal in the DNB final examination in 2013. She received FRCR in the year 2019. Since her completion of DNB radiology, she is having, till date, she is having a vast experience with many senior faculties and star walls in radiology in Trivandrum, in the institutes of Regional Cancer Center, Metro and Devi Scans. And out of her interest for teaching, I know that she's a very interested in teaching, and just for that purpose she was traveling to Kulashekaram, Sri Mugambika Institute, Kulashekaram, in the Tamil Nadu border, and was serving as assistant professor for a short period. And now she is a consultant in Anandapuri Hospitals and Research Center, and also GG Hospital Trivandrum, now a senior consultant with areas of interest in gastrointestinal, head and neck imaging, mainly the cross-sectional imaging. So I welcome her, and she'll be a good faculty for conducting this discussion on pancreatic pathologies. Over to you, Reshmi.
Thank you so much, ma'am, for those good words. So right away, I think without wasting much time, we'll start. So what I'm planning to do today is I'll be showing, I have actually around 12 cases, all on pancreatic pathologies. so I'll be showing the cases one by one. So what I expect from you, we'll start from Shilpa, right?
Yes, ma'am.
So what I'm planning to do is I'll be just showing the cases. You can start speaking once you like. I'll just scroll it and then you can just start speaking. See if you want to see any areas more specifically, you can actually ask me. So just like no, don't be relaxed. Don't get tense. It's just teaching session. So if you have any doubt, I think some echo is coming. It's okay, right? So shall we start? Is it some problem there, or I'm actually hearing some noise? Okay, fine. Shilpa, can we start? More than one gadgets are open there, Shilpa. I think that's why.
Yeah, I think that's why Shilpa.
Yes, ma'am.
Or you can all view from one. Other
You can
gadgets can be off.
Yeah, you can disconnect all other gadgets. If more than one gadget is there in one room, the echo will come.
Okay, that's fine.
So shall we start?
Yes, ma'am.
Are you able to see my screen? Shilpa, are you able to see my screen? She's gone.
Your screen is visible, doctor.
Shilpa's voice audio is not coming.
Ma'am, can you hear me now?
Yes. But still that echo is there.
Yes, ma'am.
That echo is still there. I think.
Ma'am, can you hear me now?
Yes, yes.
Okay.
I think you can disconnect all other gadgets. If all of you are sitting in the same single room. All
Yes,
of you.
ma'am. Yes, ma'am. We are sitting in a single room.
That's the problem. Okay. So shall we start?
Yes, ma'am.
Okay. You are able to see my screen, right?
Yes, ma'am.
Okay. So have this 67-year-old. The history and age of the patient is very important in pancreatic pathologies, as you know. So this is a 67, okay, 67, an elderly 67-year-old female who presented with obstructive jaundice. So we'll start with a very simple case, which is the most common scenario that we see in our clinical routine practice. You can start actually appreciating the findings, and then you can actually speak. If you want to see other faces, I can see that. You can actually start if there is something particular in the plane you want to tell, you can just tell, or you can just start explaining the findings and describing the findings. Okay.
Yes, ma'am. So this is the axial CECT sections of abdomen. So on plain axial CT,
Yes.
I'm seeing intrahepatic biliary radical dilatation.
Yes.
IHBRD is seen, there's moderate IHBRD seen involving both lobes of liver, predominantly on the right side.
Okay.
There are no definite calcifications, no calcifications in liver.
Okay. So in your right hand side is arterial phase and left hand side is a portal venous phase. See, if you have IHBRD, what is the next thing that you see?
Yes, ma'am. So the
you should look for the cause of the biliary obstruction, right? What is the cause of the biliary obstruction here? Up to which site you are seeing the dilated ducts?
Significantly dilated ducts with peripheral wall enhancement is seen. That
Okay.
is seen from the intrahepatic level, and that is seen extending
Yes.
along the involving the common hepatic duct.
Yes. I'll just help you out here. This is a cystic duct and this is the CHT here.
CHT. Both
Yeah.
are seen dilated, significantly
Yes.
dilated,
Yes.
and
Coming lower
then
down.
we can trace it downwards, still dilated.
That is the CBD, which is again grossly dilated, right?
Yes.
The
The distal CBD appears dilated. And then it appears to be
that is not the
tapering.
distal CBD. This is the proximal CBD.
Proximal CBD.
Correct. The cystic duct you are seeing joining here, and then this is the proximal CBD. And then here, what are you seeing?
So here, the duct appears narrowed in caliber with abrupt cutoff.
Yes.
And then we are seeing a heterogeneous lesion involving the peripancreatic region. The pancreatic duct appears dilated. The main pancreatic duct is dilated throughout.
Yes.
So that gives a double duct sign, positive.
Very good.
And on the arterial face, there is heterogeneous kind of enhancement.
Okay.
Involving the region of head of pancreas. I couldn't see any calcifications on plain scan in the same region.
Yes.
And the main pancreatic duct appears dilated and appears slightly irregular. There are no ductal calcifications. The distal pancreas, that is the body and the tail region, appears atrophic.
Very good.
Now that a heterogeneously enhancing lesion that we could see in the region of head of pancreas, that is seen causing loss of fat planes with the adjacent duodenal loop, the medial wall of duodenum. Can also see a diverticulum arising from the duodenum.
Very good. Yes.
Okay. And the vessels. So that is a celiac axis. Celiac axis appears normal. The branch, the common hepatic artery, is seen closely abetting the lesion. And there is loss of fat planes seen along the wall of common hepatic artery. But there is no significant narrowing of the artery.
Yes. Do you want
the enhancement of the vessel is
show
normal?
the arteries in any other planes, coronal or sagittal?
Yes, I can see. So, or coronal, ma'am. So here, the common hepatic artery arising from the celiac trunk appears to be having loss of fat planes with the heterogeneous mass lesion. And it is
from this, like, what is your diagnosis? Just I'm asking before this. You have not completely described the lesion, but what is the diagnosis?
Probably a malignant lesion arising from the head of pancreas.
Yeah, it's a heterogeneous lesion causing ductal dilatation, MBD, double ductal, everything is there. Now, what is the main role of imaging? Because diagnosis is not a very important thing in this case because it's so straightforward. Any elderly coming with obstructive jaundice with this much of dilated CBD and MPD and hypovascular heterogeneous lesion in the head of pancreas with duodenal infiltration, there's no other DD. This should be a CA pancreas, CA head of pancreas. But I want you to describe it in such a way that Why? What is the role of radiologist in imaging of carcinoma pancreas? So I want you to describe the lesion likewise.
Yes, ma'am. We have to see the resectability, whether the lesion is resectable, whether it falls into a borderline resectable category or unresectable in
Yes.
the treatment perspective.
Yes, yes. Because all pancreatic lesions, the mainstay of management is what?
Surgery,
Surgery.
followed by chemoradiation.
Yes. So we have to give a report such that it will be helpful for the surgeon. So that is the main aim.
Yes, ma'am.
And they're mainly worried about the arteries. Correct.
Yes, ma'am. Vascular invasion.
Yes. So that's why you started telling this, and there are certain terms. You said fat plane not there, abetting. So what is the exact term to be used?
Encasement. Whether there is more than 180 degree or less than 180 degree encasement.
Yes.
Because if it is more than 180 degree encasement, it falls into unresectable category.
Not like that. Not like that. What is the criteria for that? See, now you just continue your description. You said the celiac trunk is normal. I'll just show you the sagittal also. What is this? Is it normal?
No, celiac trunk appears narrowed.
Yes.
And it is irregular
This
also.
one finding you should never miss if you're describing any lesion, any pancreatic lesion. Why? What is the importance of the celiac trunk?
Because if the celiac trunk is involved, it is not resectable.
That is one point. Is the narrowing of celiac trunk any significance is there? I'm asking about not the involvement of the celiac trunk. I'm asking about the narrowing of the celiac trunk.
That also indicates a invasion by the tumor.
No, I'm not at all asking about the invasion of the tumor. I'm asking about whether there is any significance if you describe the narrowing of celiac trunk, not involvement by the lesion.
Presence of collateral vessels.
Let's see what will happen if the celiac trunk is narrowed. Here you have actually the median arcuate ligament as well as some atherosclerotic disease causing narrowing. And what will happen? How will the body compensate for that celiac trunk narrowing? From where the
There is
collateral
distal post-stenotic dilatation.
Yeah, post-stenotic dilatation.
And there's post-stenotic dilatation.
Yes, but the hepatic arterial supply will be mainly from the which artery? If there is a significant narrowing of the celiac trunk, from which artery the hepatic artery gets the supply? It's from the gastroduodenal artery.
Yes, ma'am.
Okay, because gastroduodenal artery from the inferior pancreatic duodenal artery from the SMA, the blood supply will go to the liver, the hepatic arteries. So, what is the mainstay of management? What is the surgery they do in head of pancreas lesion?
Triple surgery, pancreatic duodenectomy.
Yes. So, what is the artery they usually take along with that?
GDA.
GDA. So, when the GDA is gone in a patient with significant celiac trunk narrowing, what will happen to the patient?
There is ischemia and
he'll go for liver failure. Especially what was how is the liver here in this patient? Is it normal?
Liver appears enlarged with left lobe hypertrophy, and there is wavy surface, so likely chronic parenchymal disease.
Not likely. This is chronic liver disease. You can see widening of ears, you can see nodularity, you can see hypertrophy segment 2 and 3. So she is having CLD, right? So in a CLD, if there is compromise of the hepatic arterial supply also, then what will happen? The patient will go for liver failure. So
liver failure.
Yeah, so that's actually applicable in all patients. So in any case of head of pancreas lesions, if they're planning Whipple surgery, one thing that you have to always mention in a report is about the celiac trunk. It is not just involvement, but whether there is narrowing, because it's commonly seen, right? You have noticed in your routine practice also, we see celiac trunk narrowing more commonly. So that is one point that you should always mention in your report. Understood?
Yes, ma'am.
Clear? Okay. So that is one point. And now what is the next point that you should always see in your vascularity or vascular supply of the liver? Next point. Which is again very important for pancreatitis. Yes, very good. Come on.
Yes, ma'am. The involvement of celiac axis, superior mesenteric artery.
Okay, then see, the next point is that we should look for the anatomy of the hepatic artery. Again, very important because like the normal anatomy.
Variant
is very-
anatomy.
Yes, which is very common. We see around 50% normal anatomy, rest is variant anatomy. So in this patient, did you notice something? What is this? Can you see this artery? Okay,
Yes,
what is
ma'am.
this? What is this trunk? This is the celiac, and after that comes the
SMA.
SMA. And you just trace this artery. You're seeing this artery, right?
Yes, ma'am.
And where is it going?
Let's go to the SMA.
That is from the SMA, it is going into the
The liver. So that's a
Liver.
replaced artery.
replaced which artery?
Right hepatic artery.
Replaced right hepatic artery. Why is it important in this case? Because
is-
it is actually close to
It is
the
involved lesion.
Yes. It's actually very close to the lesion. So if they're planning a surgery, this variant anatomy is again very important. It is not involved by the lesion, but they have to always look for this replaced right hepatic artery. Again, very important. Then see this, I'll just tell, this is the common hepatic artery and you have this LHA here, which is actually going and supplying the left, and you have a separate segment 2 artery. This is the segment 2 artery. So it is two separate arteries which is arising from the common hepatic artery, these two arteries. So what is happening there is, it is actually, what is the difference between encasement and abutment?
Engagement is more than 180-degree arc of contact with the lesion.
So here, what is happening here? Just see here. This common hepatic, this is the origin of left
Yes, ma'am.
hepatic. What is happening here? Is there narrowing here?
Yes, ma'am.
So that is actually, it is, the lesion is encasing the origin
Encasing
of
the
distal common hepatic artery, origin of left hepatic artery. It is actually encased by the lesion, and obviously the gastroduodenal artery is encased and infiltrated and narrowed by the lesion. Now I'll ask you, like, what are the signs in CT by which you can tell that there is definite vascular invasion? Artery
we
or
have to
vein?
see the whether
is
it is artery or vein.
Yes.
One is the arc of contact with the lesion.
Yes.
Second
then-
is whether there is any vessel irregularity, presence of thrombus within the lesion, and then there is something called the teardrop sign that we see on the axial CT scans, especially mentioned for SMA, whether when the shape of the artery becomes like a teardrop,
Okay.
and that is due to the direct invasion by the tumor.
Okay. So here now, are you convinced that the lesion is encasing the LHA and the common hepatic artery and the gastroduodenal artery?
Yes, ma'am.
Then what is happening to the SMB here?
SMB is also like almost 180-degree encasement by the lesion.
Okay. So it is actually less than 180. It's somewhere between 90 and 180. But whether that affects the resectability?
If there is proper channel for reconstruction of the vessel, then it can be resected, the proximal and distal segments.
Yes, and less than 180 and all, they can actually shave it off from the vein. So if it's more than 180 degree, if there is a proper distal and
Segment is not available, then they can resect.
Yes, very good. So that is about the vascular. So these points you should always remember: the celiac trunk, origin, the variant anatomy, and the infiltration of artery and the vein. Next, what is the next important thing to look?
Infiltration of the adjacent organs.
Very good. Which are the adjacent organs to be checked?
Duodenum.
Duodenum, it's almost always
Infiltrated.
That they can take out in pimples. So that's not a problem. What are the other colon? So what is the transverse mesocolon and root of mesentery? These are the two areas you should always check. In CT, how will we check whether the root of mesentery or the transverse mesocolon is involved?
Usually there is fat stranding.
Yes. Then
And can you show that coronal?
which are the two veins that you always check?
Portal vein, superior mesenteric vein.
No, I'm asking about the route of mesenteric involvement. These are
The
the
first branch of
the jejunal branches.
jejunal branch of
Jejunal-
SMV.
Yes, the first jejunal branches is involved, then you can tell that there is route of mesentery involvement. And which is the other vein that is involved in transverse mesocolon infiltration, which is the vein that you always check? This vein, these two veins. What is that? This is the right middle colic vein and the gastroepiploic vein. So this is the mesocolon. You can see, you can actually trace it to the transverse colon here. This vein. If that vein is involved, then we can tell that there is transverse mesocolon involvement. So these are the things, negative points you have to always tell. Okay. And it depends on the infiltration of the veins. You have to always see the veins, the middle colic vein for the transverse mesocolon and the jejunal veins for the root of mesentery. So these are the negative points that you should always. Then what another important thing? Checking, we have to check in
presence of metastasis.
Yes, yes. Before going to metastasis, we should look for the perineural infiltration. Perineural infiltration, again, very common in CF pancreas. We have to check the origin of the celiac trunk and SMA if there is some soft tissue cuffing surrounding these vessels. Because those are the areas where we have this the
Celiac plexus.
Yes, the celiac plexus. So it's from the through the veins, actually you can go in and involve this celiac plexus. So you should always, again, that is another negative point that you should tell in any lesion in any malignant lesion in pancreas. Then of course, then lymph node. Before coming to metastasis, you should look for the lymph nodes. Which are the lymph nodes? Yes. Which are the areas that you always check?
Pancreatic region, periportal.
What are there is a name?
Portocaval lymph nodes.
I think I'll just show it. Yeah, are you able to see my screen?
Yes, ma'am.
Yeah. So these are the lymph nodes that you should always have to check in any CF pancreas. So there are actually a number of names. I'm not going to it because of lack of time. So all these are the celiac trunk, the left gastric, the common hepatic, the portal vein, the confluence lymph nodes, the peripancreatic lymph nodes. So one point that I want to tell that actually they can actually take all these lymph nodes along with the Whipple's resection. But any node which is to the left of SMA, if you see any lymph node to the left of SMA, then it becomes not resectable. Yes, that is the one point. So in CT, you to always see if there are any lymph nodes to the left of SMA, and also any pancreatic lymph nodes that will become unresectable. So all these points you have to see the NCC and resectability criteria about the lymph nodes, and finally this is the checklist by which you have to finally conclude. Okay, so now you are looking for messages. Is there any lesions in liver here?
Yes, ma'am. There was a lesion.
What can it be?
And I can't see this.
This is
and I can't see the image. Okay. Okay. So on the arterial face, there was a hyper-enhancing lesion. There's a heterogeneous enhancing lesion involving the right lobe of liver, and that is showing heterogeneous peripheral enhancement that is more evident on the portovenous face than on the arterial face, with central hypo-enhancing areas.
So what can it be? Can it be metastasis or some other lesion?
But in this context, possibility of a metastasis appears likely.
Actually, will you see such sort of an arterial enhancing metastasis from CF pancreas?
No, less likely, unless it is a neuroendocrine tumor.
Very good. So this is unlikely, but this one site is actually very common for CA pancreas, this subcapsular, because it always goes through the peritoneal spread. So this is one area which is very common, and you can see some mass effect is there. some necrotic areas in the center. There is no washout actually, because in CLD, if you see a arterial enhancing lesion, what is the first thing that comes to your mind?
HCC. Possibility of HCC.
So is this a HCC or metastasis imaging wise?
Imaging wise, it is having a central non-enhancing area with a targetoid appearance.
Yes.
And so in this context, more likely to be metastatic.
Yeah, in HCC, in the venous phase, this should be hypo, right? So that is the main, that is how we actually describe HCC. So arterial enhancing, but it will be hypo compared to the rest of the liver parenchyma in the venous phase. And you see a delayed, yeah, and you see a delayed enhancing pseudocapsule, which is again is not here. So in this context, you will like be, what will be your impression in this case? So what is your next line of management?
So the final diagnosis would be malignant lesion arising from the head of pancreas with infiltration, with vascular encasement, adjacent organ infiltration, and obstructive biliopathy, with the metastatic lesion involving the liver, and features of chronic liver disease.
Okay. So if this lesion was not there, if this liver lesion was not there, whether it is resectable, non-resectable, or borderline resectable?
In the presence of liver lesion, it becomes a distant metastasis and it is unresectable.
Exclude the.
But in the absence of excluding, still there is encasement of the vessel.
So whether it's borderline resectable or non-resectable? Borderline resectable. It is borderline resectable. That's one point that you need to remember, that origin of the CHA, the left, the right, RHA, LHA, still they can actually resect it. It's borderline resectable. Only if it is involving the origin of celiac trunk or SMA, it becomes
unresectable. Okay, or aortic involvement.
Yeah. So in this lesion, this is little atypical. So actually, we need to do an FNAC, ultrasound-guided FNAC from this lesion to confirm that if it is metastasis, then it straight away becomes non-resectable. Okay, so that is the management plan. We did actually an ultrasound FNAC from this liver lesion, which actually turned out to be metastasis only. So this is an atypical metastasis from CA pancreas, which is arterial enhancing. Okay, so right away this becomes non-resectable and the patient will go for chemotherapy. We will go to the next case. Sukanya. We can now actually, the first case that we took this much time because this is how you need to approach a CA pancreas or any malignant lesion in pancreas. So everybody should actually have a protocol or a set format for reporting. That is, one is localization, two is the enhancement pattern. Then look for the rest of the pancreas and what is the ductal involvement. We need to give the measurements of the CBD, the MPD, and then vascular involvement, which is very, very important. Look at the celiac trunk origin, the variant anatomy, abutment, encasement of all the arteries, all the adjacent veins, adjacent infiltration. Specifically look for the route of mesentery, transverse mesocolon, something we tend to overlook. Then look for the perineural infiltration. Again, if you don't look for it, we'll miss it. And then obviously all the lymph nodes and metastasis. Finally, hope it's clear. Sukanya?
Yes, ma'am.
Ready?
Yes, ma'am.
Okay. This is a 27-year-old, okay, a 27-year-old female who actually presented with hematemesis. Okay. Just look at the findings because now we want to see more cases. The approach we have already discussed in the first case. So I just want you to tell the findings, the important findings, and then we'll go right away to the diagnosis because we want to see more cases. Okay, what is striking here? She is a 27-year-old female.
IHBR is there, ma'am?
Yes, very good. Significant IHBR here, but remember that she doesn't present it with obstructive jaundice. There is no obstructive jaundice for this patient, despite having this much of IHBR. Okay, what are you seeing here?
I'm a thick-walled.
Okay.
A thick-walled cystic lesion can be seen.
Yes. And what is the generalized, like, why do you think the patient presented with hematemesis? What do you think the reason is? What is the reason? What is happening to the spleen here? What is happening to the portal vein?
Spleen is enlarged, ma'am.
Yes. So
And
what does it indicate? This is a very rare case. Not very. The diagnosis is not very rare, but the presentation is actually very rare.
extrahepatic portal veins
Very good. Very good. This is just like an extra EHPVO.
due to this cystic lesion, ma'am.
Very good. Very good. So that is actually the cause. So there is portal hypertension, splenomegaly, multiple fundal varices, esophageal varices. That is the cause of a hematemesis.
Yes. Yes.
Okay.
Yes.
Okay. So now coming back to the lesion, you can now actually start describing the lesion.
Ma'am, there is a thick-walled cystic lesion with heterogeneous contents, heterogeneous attenuation,
Yes.
arising from the head region of the pancreas.
Yes. Okay. So again,
And
which I told, first is localization. You said it is in the head of the pancreas. Now you
Yes,
tell
yes.
the morphology enhancement pattern. So we'll go in a set approach. Then it will be very easy for you. What is the enhancement pattern?
ma'am, the body. Ma'am, actually, the cystic lesion is involving both the pancreatic and peripancreatic tissues.
Okay. But it is
The
actually,
body and the tail region of the.
it is actually, you will see, you are seeing actually the close sign here. So it is actually.
Yes, ma'am. Yes, ma'am. It is arising from the head region with a close sign, and the body and the tail region is showing a homogeneous low enhancement.
So it's a predominantly cystic. You see some solid areas.
Yes, ma'am. It is heterogeneous.
Yes, and it
Some
is
solid areas.
some calcification is there. And what
In
is
the periphery, we
here?
can.
Yeah, what is happening here? It is actually, it is severely compressing the portal vein.
Portal vein.
It with
Causing.
some thrombus here, and the biliary duct is also significantly it is compressed.
Dilated. Yes, ma'am.
But what was the striking feature here? What is not there? That you should always tell in a.
Ma'am, pancreatic duct is not dilated.
Very good. Very. What is which is one point which always differentiates from
malignant
adenocarcinoma.
adenocarcinoma.
So that is
Yes,
one
ma'am.
point you should always tell and
Yes.
understand that. So despite this a large lesion with this much of CBD dilatation and portal vein compression, it is not causing ductal MPD dilatation, isn't it?
Yes.
So what do you think this is?
Ma'am, it could be SPEN.
Yes. So very good. So that is the first diagnosis. Will a SPEN.
Even though it is not in the usual position, the features are suggestive of SPEN and the age also.
Yes, so that is why the importance of age is very, very important in pancreatic lesions. So she is a 27-year-old female, a head of pancreas lesion, and this is a typical appearance that you see in SPEN. A cystic lesion, it's actually a solid cystic lesion.
Solid cystic lesion.
And you see some
heterogeneous.
Some like the papillary projections like here. You can see the peripheral calcification. This is also characteristic of SPEN. But here, what is unlikely or what is rare is it is actually causing
obstructing.
What is the usual picture of SPEN? Will it infiltrate the vascular structures or
no, ma'am? No, ma'am. It won't infiltrate, but
it will.
It can cause comfort. It won't infiltrate vascular structures.
Okay. So this is the MRI of the same patient. So a lot of ascites is there. So features of portal hypertension. So what was done in our hospital is that, because what is the management of the patient?
Ma'am, resection, ma'am, because 15% chance of malignancy is there.
Okay, very good. So this has to be resected. But in a case of portal hypertension, is it very easy with this much of
it is not
compression? So
No,
what is the management line? Any idea? So you can actually, the answer is there in the CT. This is the third imaging that we have done for this. Any clue? One organ is missing.
splenectomy, ma'am.
Splenectomy and we have actually, our surgeon has done a splenorenal shunt. If you can just see, just trace this, it is actually going into the splenic vein. See,
Yes.
this is the splenorenal shunt just to reduce the portal hypertension. Now after this, you see the ascites has completely disappeared.
Reduced. Yes.
Reduced, and you can clearly that thrombus and ISBRD, it is still there, but the portal vein thrombus is not there. And it is actually, you can see it's not actually, it's just played actually. It is not infiltrated. See the portal vein?
Yes, ma'am.
It is narrowed because it's a chronic obstruction, but it is not infiltrated. And even the arteries are actually encased within this fibrous. So this is one point again favoring a SPEN. The SPEN always have a pseudocapsule, a fibrous pseudocapsule. It's just an inflammatory reaction surrounding. This is the main lesion. So these are all the fibrous reactive soft tissue thickening. So during the surgery, they could actually take the whole thing out. They could just shave off the lesion from this portal vein. There was no need of any portal vein reconstruction, and the patient is absolutely fine now. So the final HPR came out to be SPEN. So this is a very rare presentation where a young lady presented with hematemesis due to the chronic portal vein obstruction. Okay. Hope it's clear, and the diagnosis. Do you have any doubt on this?
Yes. No, ma'am.
Okay. We'll go to the next case. Now we'll just quickly run through the cases. This is Rabia, right? Okay, this is again a companion case. This is again a typical SPEN in the tail of pancreas. Again, I just wanted to show you, but here one more finding is there. Can you identify? This tail of pancreas lesion is again a SPEN, but can you identify any other lesion in pancreas?
There's one hyperenhancing in the head of pancreas.
Head of pancreas.
Can you scroll?
Yes, one second. You can see plain arterial portal.
In arterial phase, we can see there's one hyperenhancing lesion and in the body, mid body. It's seen mainly in the arterial phase.
This one?
Yes, ma'am.
Yeah, so this is one point that I wanted to tell, that it is actually easy to miss out a lesion in pancreas. So you have to carefully look for a lesion in all the phases, because in venous phases almost always all the lesions except the CA pancreas, it can be isodense. But if you see it clearly, there is a bulge here in the head of pancreas, in the body of pancreas. Sorry. See? Body of pancreas, and you can see some necrotic area within it. Can you identify this? Some heterogeneous enhancement is there. So this is actually an exophytic lesion from the body of pancreas. Then you have a typical lesion like a SPEN here. So this is again another rare presentation of a multifocal SPEN. This is again, surgery was done for this patient, and both the lesions turned out to be SPEN. Okay. So this is just a companion case. You stay there. We'll go to the next case. This is again, I just wanted to show you another companion case, not for discussion. Again, this is again a 37-year-old male patient who actually presented with obstructive jaundice. Any idea what is this? Any DD? I just want the diagnosis, not description, nothing. I just want to tell that, just to show everyone that something also can present like a head of pancreas lesion. It's again a highly infiltrative sort of a lesion with obstructive jaundice. But when you see that it is arising from the
Hyperenhancing
what
head
is
of
this?
pancreas.
No, this is actually
The wall.
duodenum. It is actually arising from the duodenum. You can see the one wall here, then you are seeing this lesion. It's an exophytic lesion which is arising from the second part of the duodenum. So what is the DD? Exophytic lesion arising from duodenum. Any small bowel?
It could be just.
Yes. Yeah, so this is just a companion case. I just wanted to show that it's not a pancreatic per se lesion, but such a lesion also actually, again, young male who presented with obstructive jaundice. The final diagnosis was a just from duodenum. Okay, we'll go to the next case. This you can actually see the case and describe. Okay. This is a 40-year-old male. Presenting with obstructive jaundice, 40-year-old. You have the plain and arterial here. What is there a ISPRD here? You can start describing whatever like we are seeing, you can actually tell.
The plain and plain CT axial section shows mild IHPRD in both lobes of liver.
Okay, so
dilatation
again,
of the CBD is also seen.
Okay, do you want to see any other lesion? Anything striking in plain so that I can actually show you another phase? Is there any striking in plain? Nothing, right? Okay, I'll show you the portal.
There are no.
Okay, so this is the arterial and this is the portal. What is it? What is the cause of the biliary obstruction?
There's a hypoenhancing area involving the uncinate process.
Yes.
And the mid body.
Okay. Okay, so you are actually seeing multiple lesions, correct?
Yes, ma'am.
You can concentrate in the portal venous phase. You are seeing one hyperdense lesion here.
And in the uncinate process.
One lesion here. So you're seeing one in the tail, one in the body.
Okay.
Here in the head of pancreas, and what that is actually causing the what?
The obstruction, IHPRD, upstream dilatation, CBD and IHPRD.
Yes. And then you have a large lesion here in the where?
Uncinate process.
Uncinate process. So you have 4 lesions, one in the uncinate process, one in the head of pancreas, one in the body, and one in the tail. Now start describing like the morphology. Now you have to come to the DD of these lesions. Correct?
Yes, ma'am. So in the plain CT, we didn't see any calcific areas within the lesions.
Very good.
On post contrast, we are seeing there is hypoenhancing lesions. That is multiple lesions involving uncinate process and mid body, body and tail. It is pancreatic duct doesn't show any dilatation.
Yes, very good. That is one point you should always tell.
And there is
what is striking? What is the enhancement pattern?
It is hypo-enhancing and it is multiple lesions.
Hypo-enhancing, is it heterogeneous, homogeneous,
Homogeneous
mildly enhancing, intensely enhancing?
Mildly enhancing lesions.
Mildly, homogeneously enhancing. We are not seeing any heterogeneous areas within it, correct?
No necrotic areas, no non-enhancing areas.
Yes. It's sort of a homogeneously, mildly faint enhancing lesions, multifocal. And what is another point that is striking here? See the uncinate process lesion. What is happening here?
The lesion, the vessels are seen going through the lesion, coursing through the lesion.
And is there any infiltration, narrowing, thrombosis? It is going as if nothing is happening to the coronal.
It is seen.
The lesion, that the arteries are completely encased within the lesion.
Vessels are seen coursing through the lesion.
But whether I'm asking you whether there is any.
The vessels are showing normal contrast enhancement within the lesion.
There is no narrowing, correct? Because
yes, no narrowing, no contour irregularity or non-enhancement.
Yes, very good. And why do you think this artery is so prominent? If you see such a prominent gastroduodenal artery, so much tortuous, large, what is the next thing that you should see?
Celiac trunk. Celiac trunk, if there is any stenosis.
Yes, very good. So, what is happening here?
Celiac trunk, there is stenosis with mild post-stenotic dilatation.
Okay. And then you have this tortuous gastroduodenal artery. That is the main supply of the hepatic arteries. So again, I am actually stressing the point again and again that in any pancreatic lesions, you should always look for the celiac trunk origin and the gastroduodenal artery. Okay, now coming back to the diagnosis, you can see the artery is actually encased within the lesion without any thrombosis. There is no MPD dilatation. There is a biliary obstruction is there. And now what is another, do you find any other findings that help you reaching the diagnosis?
Ma'am, there are small volume lymph nodes are seen. Multiple are seen in the retroperitoneal region.
What is this? Is this a small volume?
Okay, that is enlarged lymph node.
Okay, so that is actually much below, it is actually to the left of SMA, much below the level of, even it is just below the level of the renal arteries.
Yes, ma'am. Pre-aortic lymph nodes.
Okay. This is sort of it's a large mesenteric lymph node here because it's adjacent to the jejunal branches. Okay. Now, do you have any clue to the diagnosis?
And looks like lymphoma.
Portal vein. So all these things you should actually mention. I'm not going in details to that. All the vascular infiltration, abutment, encasement, everything should be mentioned. But now we just want to go to the diagnosis of this case. Any clue? These are typical.
It looks like lymphoma, ma'am. Multifocal, mildly enhancing lesions with infiltration to the. It's seen infiltrating the with vessels coursing through the lesion, but with no involvement. There is no thrombus or contour irregularity of the vessels.
Correct. Good. Very good. So this is a typical pancreatic lymphoma. And what are the points favoring lymphoma in this patient?
There are the first thing is the enhancement pattern. There is almost homogeneous with no necrosis.
Very good.
There are no calcific areas. Multifocal lesions.
Yes.
And
multifocal or unifocal. That's not a differentiating feature actually. Okay. Then
and associated enlarged lymph nodes.
Yeah, any lymph node, if you see in a pancreatic lesion below the level of the renal vein, that's how they say. Below the level of the renal vein, if you see a large bulky lymph node, again, that is one point that favors a lymphoma than a ductal adenocarcinoma. Okay, because there are no other lymph nodes anywhere. You're seeing only a bulky lymph node just distal to the pancreas. This is not a typical lymph nodal involvement in ductal carcinoma. So these are the points that favors pancreatic lymphoma. Okay, very good. So we'll go to, this is again the MRI of the same patient. Just want to, this is the MRCP. And in T2, these lesions will be intermediate on, because it will be hyper to the pancreatic parenchyma, but not very bright. This is how a typical lymphoma will occur. And this is the lymph node. And all these lesions are showing diffusion restriction, again, which something which favors a lymphoma. So we'll go to the next case. Shilpa. This is again a young lady, 39-year-old female.
Yes, ma'am.
Yeah. Again, now like we'll go to the main findings, the differentiating points, diagnosis. Now like rest of the cases, we'll just go like that. What are you seeing here?
Ma'am, can you scroll that again?
Yeah. This is just a non-specific finding, non-specific symptoms. 39-year-old female just presented with an upper abdominal pain. That's it.
This is a portovenous phase showing a heterogeneous lesion with predominantly mild peripheral enhancement and central hypoenhancement involving the infrapancreatic region.
Okay, you can see all the faces now, right? Yeah. Is there any multifocal lesion, single lesion, location, enhancement characteristics? Single lesion, multiple lesion?
Multiple lesions are there, ma'am. Multiple heterogeneously enhancing lesion with fluid density areas.
Okay.
And that is seen along the region of the head and also just below the level of pancreas.
Yeah, you can
Where we
actually
see the largest lesion.
Yeah, you
and
can
that is
see actually
yes,
some part of the uncinate process. Again, you can see just going like a claw here. So it is involving the uncinate process of pancreas. There is a big lesion here. It is extending into the root of mesentery. And then you have multiple lesions here, closely abutting the duodenum. And if you see closely, I'll just sometimes it will be very difficult for you to appreciate this finding. This I'll just show you. There is a small submucosal lesion here. Can you identify this one?
There's a bulge.
Yes, yes.
Focal abnormality of the submucosal hyperenhancement.
So here you have, how do you describe this lesion in the duodenum? This is duodenum, right? D2 of duodenum.
Yes, ma'am.
So how do you describe this lesion?
That is mildly enhancing focal contour abnormality involving the lateral wall of second part of duodenum.
So where do you think this lesion is? Mucosal, submucosal, or something from outside compressing the duodenum? How is it going to help in the diagnosis of this case? Something
it is having a convex inward border.
Yes.
Could be like submucosal.
Very good. So this is a submucosal duodenal lesion. Submucosal duodenal. You can see actually the mucosa here. So this is submucosal duodenal lesion, and you are seeing multiple lesions posterior to the duodenum. So everything actually is concentrated
Yes.
in and around the D2 and D3 of
Duodenum.
duodenum. And
D3 segments of duodenum.
it is involving the uncinate process of pancreas also.
Uncinate process of pancreas.
In a 39-year-old female with you see peripheral ring-like enhancement, the largest lesion, central necrosis or cystic degeneration. What is the DD that comes to your mind? I've given you so many clues.
One thing could be paraduodenal pancreatitis with large cyst formation.
Pancreatitis, there are no signs of any inflammation anywhere. The fat looks normal. And how can you explain a submucosal lesion in pancreatitis? What is the most common lesions that you see? The enhancement pattern is not very typical, but if you see intensely enhancing similar lesions, what is the first DD that comes to your mind?
Neuroendocrine.
Neuroendocrine tumor. Very good. So that is one DD that you always have to keep in mind. If you see, because this is one area which is very common for neuroendocrine.
Neuroendocrine.
The duodenum, what do you call that triangle?
Gastronoma triangle.
What is the gastronoma triangle?
Yes, ma'am. Gastronoma triangle is bordered by the confluence of cystic duct and CBD, the second and third part of duodenum, and the pancreatic head and neck. So the area which is seen between these, between the triangle formed between this area will form the gastronoma triangle, and that's the most common site for a gastronoma.
Gastronoma. So this is one again area very common for neuroendocrine tumors. But is this looking like a typical neuroendocrine tumor?
No, because we expect to have hyperattenuation and also hyperenhancement for a neuroendocrine tumor, but the larger ones can show cystic changes or calcification and necrotic areas. Multifocality can be there.
Yes. So is this fitting into your diagnosis of neuroendocrine tumor?
Yes, ma'am. With that submucosal lesion, we can explain the possibility of a multifocal neuroendocrine tumor, which is heterogeneous and large, showing heterogeneity.
Yeah.
With
So and from this, do you know the grading of like different types of neuroendocrine tumors?
Yes.
Pancreatic neuroendocrine neoplasm.
According to the
recent 2016
according to the recent 2017 WHO classification, it has been divided into the pancreatic neuroendocrine tumor, which can be further divided into 3 grades: grade 1, 2, and 3.
Yes.
So the grade 1 and 2 will have a size less than 3 centimeters, and usually there will be homogeneous lesions without any cystic areas, necrosis, or heterogeneity. And the grade 3, that is more than 3 centimeters in size, with cystic areas, calcification, and necrosis. And then we also have poorly differentiated pancreatic neuroendocrine carcinomas. Those lesions would be having.
So out of this, what do you think this lesion is? Because that comes under the first DD, right? You can definitely give other DDs also. Like what other DDs can you think for this patient apart from a neuroendocrine tumor? Because definitely in your exam you have to give DDs.
Yes, sir.
See, if you're not seeing this submucosal lesion, you're seeing multiple necrotic sort of lesions in a young lady. You can always think the possibility of a tuberculosis. You can actually
granulomatous lesions.
Granulomatous lesions with lymph nodes. That is one DD you can give. All those granulomatous lesions. Yes, all those granulomatous lesions you can give us DD. Any other DD? Lymphoma again.
Necrotic lymph nodes.
Yeah, you can give all the DDs of necrotic lymph nodes in this case.
Lymph nodes, yes.
Lymphoma again. Can you give us DD or down the line?
Lymphoma can be a DD if the patient is immunocompromised, and in view of the larger lesions with necrotic areas can be seen post-treatment or in immunocompromised patients.
Yeah, but if you find the submucosal lesion here, then actually you can't explain any of these DDs. Yes. So you have to ultimately come to the diagnosis of a neuroendocrine neoplasm. So you have told different type of neuroendocrine neoplasm. So out of which, like, what fits into this? More?
This is a larger lesion. We are seeing larger lesions, definitely more than 3 centimeters in size.
Yeah,
So it
is
should
around
fall
7
into a
centimeters.
grade 3 pancreatic neuroendocrine tumor, or we cannot rule out the possibility of a neuroendocrine carcinoma also.
Yeah. So what are the what are the features which favors a neuroendocrine carcinoma? What are the features?
Neuroendocrine carcinomas, they'll be usually large presentation with ill-defined margins.
Mhm.
And then there'll be one point which makes them different is the vessel invasion. There can be involvement of the vein. The venous invasion is more common with the pancreatic neuroendocrine carcinomas. Other than that, they can show heterogeneous uh, characteristics like presence of calcifications, cystic areas, necrosis,
Yeah. So
and poorly defined margins.
yeah, poorly defined margin. That is one point which
There's
always
more-
favors. Because
And
here
there's
and
in, metastasis.
yeah. So what is the, in which phase you look for metastasis in liver?
In liver, we have to, in view of the neuroendocrine tumor, we have to look in the arterial phase for seeing any hypervascular metastasis. But it can also be hypovascular or even isodense lesions. So first, we have to see the arterial phase.
Yeah, you have the arterial phase and this is the portal venous phase. So do you see any lesions here?
There is some enhancement,
Actually,
subcapsular aspect of the
because the primary lesion is not showing arterial enhancement. So you can't expect the metastasis also to show arterial.
to be hypervascular.
Always
Yes,
look
ma'am.
for
Hypo. In this case, we expect to be metastasis also to be having similar morphology to the
Yeah.
primary lesion.
yeah. So see this, you see multiple subtle, it is only seen in the portal venous phase. So you have to always
Yes.
check for liver metastasis in the portal venous phase.
Multiple
see-
small hypovascular lesions, hypoenhancing lesions are seen
Yeah.
scattered in the right lobe.
So in this context, so what is your final diagnosis?
So this could be high grade or grade 3 pancreatic neuroendocrine tumor showing cystic changes with which is multifocal.
So you're seeing metastasis. So what should be your final diagnosis?
Pancreatic, in view of the metastasis, we can say that to be pancreatic neuroendocrine carcinomas.
Yes. So ultimately, the biopsy and surgery, everything was done for this patient. Ultimately, the biopsy came as multifocal neuroendocrine carcinoma. Okay. So this is again a little atypical, but if you see, you can actually come to the diagnosis of a NEC.
Yes.
Okay, very good, Shilpa. Now, like, we'll just in 10 minutes, we'll see the last 5 cases. It's a 67-year-old female.
Yes, ma'am.
Okay. Okay, now it's all rapids. You can just tell the finding, no description, relevant findings, diagnosis.
Can I see the plain scan also, ma'am?
67. No, planes and nothing significant. That's why I didn't take. No calcification, nothing. It's all hypo. So this is the arterial, portal, and the venous phase of a 67-year-old female. Where is the lesion?
Head of pancreas, ma'am. There's a large heterogeneous lobulated lesion involving the head of pancreas, which is showing heterogeneous kind of enhancement with multiple non-enhancing areas suggestive of necrosis. The periphery of the lesion shows enhancement that is hyperenhancing in the arterial phase. There are multiple small septal-like areas within the lesion, which is also showing enhancement. And lesion.
See, despite the large size of the lesion, what are the 2 negative points you would like to say?
Duct dilatation is not seen.
Yes. It's almost, what is the enhancement
Can you
pattern?
scroll it?
What is the enhancement pattern?
Heterogeneous with peripheral enhancement, hyper enhancing rim and central, multiple central non-enhancing areas.
Okay.
There is some central hypo-enhancing areas also seen in like a spoke wheel appearance.
Yes. Very good. When I
And
change
there's
the
infiltration
window,
in the
when I change the
Yes,
window, there's something very characteristic here in the central. That's what you were telling.
scar formation.
Yes.
So on the delayed scan, we are seeing that central hypo enhancing and hypodense lesions as enhancing. So that is delayed enhancement, suggesting scar formation in the center.
67-year-old female. Diagnosis?
Serous cystadenocarcinoma. Serous cystadenocarcinoma.
Serous cystadenocarcinoma or serous cystadenoma?
Because the lesion is very much heterogeneous and there's also infiltration into the duodenum.
Is it infiltrating the duodenum, or you can see this? You can actually see the mucosa, see the wall very, very nicely, correct? See? Even though it's a large lesion, actually you can see the mucosal folds, everything so nicely.
Okay. Serous cystadenoma.
Yeah, and do you see serous carcinomas very commonly? What is the normal the prognosis, or how is it behave? A serous cystadenoma?
Serous cystadenomas are usually benign tumors. They have a very good prognosis.
Yeah,
They
very,
are
very highly unlikely to become
turn malignant.
Yeah, so this is again a not very classical, but again a head lesion with so much vascularity. Why the serous cystadenoma show this much of enhancement?
Because they have a rich vascular supply.
Because of the intense traumal vascularity, because they have so much of
Traumal.
trauma. Because so don't get confused this with any other malignant lesion, because this is one of the appearances of a serous cystadenoma, where you can see multiple vessels which is supplying. You can see all these vascular pools here, and which is actually you can see it is early draining vein. You can see. So this is because of the highly vascular nature. So serous cystadenomas can show this much of a highly vascular or a stromal enhancement. So don't mistake this for a malignant lesion or a paraganglioma or a NET. And what is the imaging feature which helps in diagnosis of this? If you see this, what is your next line of investigation to confirm that this is a serous cystadenoma? What are the differentiating, what are the points that help? What is the next
in serous cystadenoma, that is usually a multi-loculated cystic lesion, and it will be having well-defined lobular margins.
You should
There is
take
calcific.
MRI, you can see the microcystic appearance, which is very characteristic of serous cystadenoma. And the delayed enhancement, you will see washout.
For the scar.
The intense vascularity, washout, and the scar you can see. These are the ways you can differentiate serous cystadenoma from other lesions. Again, this is again a companion case. Just want to show you again another case. Are you able to appreciate a lesion here?
Yes, ma'am. There is
what do you think?
Heterogeneous hypoenhancing lesion involving the body of pancreas with contour bulge.
Yeah, and some enhancement related. Correct.
And some enhancement, and that is showing some communication also. Some linear components are seen.
Okay, but this is high up. There is no communication with the pancreatic duct. This again came as serous cystadenoma. So just want to tell you that any enhancement within the lesion, you don't consider this to be a malignant lesion, because serous cystadenomas can have this multiple variable appearances in pancreas. Okay. So that comes to the cystic lesions of pancreas. And again, what is this? This is again a middle-aged 48-year-old female. Macrocystic lesion.
Large unilocular cystic lesion showing peripheral enhancement with few internal incomplete septations within, and that is arising from the head of pancreas.
Mhm.
Multiple small locules are seen towards the periphery.
Yes.
There is no
No
significant
solid,
IHBRD,
yeah, no
there's-
solid enhancing areas, no septations,
no
no
septation,
IHBRD, no
no pancreatic duct dilatation.
a middle-aged female coming with a macrocystic lesion. What is this?
Mucinous cystadenoma.
That should be a first.
Mucinous cystadenoma.
Yes, cystadenoma, because there is no features of carcinoma in this patient. So what are the features of carcinoma?
Malignancy.
What are the features of malignancy in any cystic lesion of pancreas?
Presence of mural nodules, especially when the size of the nodule is more than 5 millimeters.
Mhm.
Thick enhancing septations more than 3 millimeters in thickness.
Mhm.
Presence of calcifications. Mucinous cystadenomas can show peripheral wall calcification, but if the calcification is seen more towards the center, then it becomes a suspicious feature. And then presence of associated duct dilatation,
Okay.
especially if the pancreatic duct is dilated more than 5 millimeter. 5 to 9 is a worrisome feature, and more than 10 millimeter is definitely a high risk characteristic.
Okay. Yeah, so those are the features that you should always look for. If a solid nodule, enhancing wall and septa, and if the MPD is more than 10 mm. Okay.
10 mm.
These are the worrisome features that you have to always check in any pancreatic cystic lesion. Again, another spotter. What is it? This is an elderly female. Again, incidental lesion. What is the striking
there's a-
feature here?
Communication to the duct,
Yes. So what it should be our first DD?
IPMN.
IPMN. Yes. So if you see communication with the pancreatic duct or lobulated lesion, you should always think of IPMN as the first.
IPMN.
And what are the again other features of IPMN?
That can be side branch IPN, main branch IPN, or a mixed type of IPN. Again, we have to see for the size of cyst. So if it is less than 5 millimeters and if the patient is asymptomatic, fully follow-up is required. But if the size of the cyst is more than 5 millimeter, or if the patient is symptomatic, we have to follow up the patient.
Mm-hmm. Okay, so you are actually well versed with all the theory, so that's not a problem. Okay, so we'll go to the next case. Again, an elderly female, 70-year-old female.
Yes, ma'am.
Very non-specific complaints, actually. But you're seeing a large lesion here. Can you describe the lesion and come to the diagnosis? Do you want to see any one face as such rather than seeing the four together? Who was there? Shilpa or Sukanya? Who was there?
Shilpa. Ma'am, Shilpa.
Okay, Shilpa, yeah. Are you able to appreciate? You're seeing the case, right?
Yes.
Do you want to see one face in particular? Are you like confused seeing all the faces together? Then I'll just show you one face. Which face do you want to see?
Venous face.
Venous face. Okay, now I have the portal venous and the venous face here.
There is intrahepatic biliary radical dilatation noted.
Yes.
And then there is a large heterogeneous lesion that is seen that's a large lesion that, seen in the region of body and tail of pancreas with extension towards the lesser sac.
Yes.
The lesion appears to be ill-defined.
Yes. Do
with
you, hmm.
communication to the communication fistula is there. So there is that is a
Very good. So that is the feature that is striking here. So you have a large lesion in the tail pancreas, and you are seeing what is this?
communication with the bowel,
Yes, communication with this. This is stomach, and this is
stomach, colon,
colon.
descending colon.
Yes. So you have a fistulous communication here, and actually you have one more communication with the duodenum also. This one. Okay, so you have multiple communication, fistulous communication with the bowel. And what do you think the morphology enhancement? What is from the first look? What do you think the density of the lesion is?
It is heterogeneous with necrotic areas, multiple necrotic areas,
Mhm.
fluid density areas are seen.
Yes. Yes, it's a predominantly cystic lesion, correct?
Yes,
But rather than a solid lesion, it's a predominantly cystic lesion. In the plain CT, it is around 25.
okay. So had some high density fluid.
So this appearance with so much of heterogeneous, is there solid enhancing areas with it?
Yes, solid enhancing areas are seen within.
Yes. So what do you think? This is a malignant lesion or a benign lesion or an inflammatory lesion? What is happening here to the head and ancillary process of pancreas? Did you notice this?
Yes, that appears atrophic, and we're not seeing that actual pancreatic parenchyma well, and there's significant peripancreatic fat stranding and nodularity. There are peripancreatic lymph nodes seen.
Yes.
The transverse mesocolon shows stranding.
Yeah, so this is in the first case actually I told you to look for the involvement of the transverse mesocolon, the mesentery. So what is happening to the superior mesenteric vein here?
Narrowed. Superior mesenteric vein is narrowed significantly, and then it is flattened.
Yes, and what is happening to the jejunal branches?
That is also narrowed.
It's completely thrombosed. You're not seeing it.
Thrombosed.
See, you're seeing the distal jejunal branch here, and then you're coming here. It is completely thrombosed. So, what did I tell you in the first case? If you see thrombosed or infiltrated jejunal branches, then the lesion is extending into
the small bowel mesentery.
into the mesentery. So that is one point. Again, if it's resectable, it is important for the surgeons to know. And again, look for the transverse mesocolon involvement. Again, it is actually going along the middle colic vein. So it is involving the transverse mesocolon. So it's a highly infiltrative. You can see the splenic artery completely infiltrated. The origin of the celiac trunk, it is partially encased. The left gastric, it is encased. The common hepatic artery is encased. So it's a highly, so what do you think the lesion is? A benign or malignant? That's the first thing that you need to tell.
Malignant lesion, ma'am.
Yes. So what can be the malignant nature? What do you think the malignant? Is this a pancreatic ductal adenocarcinoma or some other carcinoma? By just looking at the morphology, the density of the lesion? I told you it is mildly, it's predominantly a cystic, correct? It's a predominantly cystic, mildly hyperdense on plain CT, some solid enhancing areas with so much of infiltration, CBD obstruction. So what is the characteristic? What is this density? What can be? What can it be?
Can be malignancy developing in a pre-existing case of complicated chronic pancreatitis?
Yeah, definitely. Yes, there is CCP, there is chronic calcific pancreatitis. That I agree. So, see, what is the most common malignancy that occur in CCP? Just ductal adenocarcinoma.
Ductal
So
adenocarcinoma.
I'm asking you whether this is a ductal adenocarcinoma or is it something else?
It looks more infiltrative and aggressive in nature.
Ductal adenocarcinomas can be infiltrative like this. What can?
But with the fistula formation and so much of vascular.
And the patient is absolutely fine. She just have some non-specific complaint. There are some multiple calcifications. Did you notice that? Multiple calcifications in the septa, in the wall,
Yes, ma'am.
cystic lesion with heterogeneous enhancement. It can be the density, the clue, the density is the clue. Mildly hyperdense. I'm giving you so much of clue with peripheral calcifications.
Usually this is adenocarcinoma.
Very good, very good. Okay, so this is this is more looks like a mucinous carcinoma. It can be either an IPMN or a mucinous cystadenocarcinoma. So finally, actually, this was so much. This is actually borderline resectable because the celiac trunk and SMA was not involved. Actually, they could actually go for a very extensive surgery. This is borderline resectable, but considering the other status, actually we didn't go for surgery, but they could easily take a biopsy from the endoscopy because it's actually opening into the
Stomach.
stomach and the colon. So they could see mucin actually coming out of it, and finally this turned up to be a mucinous carcinoma, mucinous adenocarcinoma. Okay. And the last case, again, mimic of pancreatic lesions. I'm giving you the clue. Sometimes this can be mistaken for pancreatic lesion. What is it? What is the common mimic that you usually see?
Chronic pancreatitis,
Chronic-
mass-forming chronic pancreatitis.
Yes, mass-forming chronic pancreatitis. So what are the points that help you in differing pancreatitis, chronic pancreatic inflammatory mass from adenocarcinoma?
In chronic pancreatitis, there is a duct penetrating sign. That is, we can see the duct smoothly tapering through the lesion.
Yes.
And in case of adenocarcinoma, there will be abrupt tapering, abrupt narrowing of the duct.
Yes, so that is one point. And you always look for features of pancreatitis, pancreatic fat stranding. Here and also you can see a heterogeneous lesion here.
Yes, ma'am.
Some enhancement is here, and you can even actually see infiltration of the stomach. You see a linear structure going into the stomach. But
Yes,
finally, if you're suspecting what should be a next line of investigation? If you're seeing, if you're doubtful any pancreatic lesion, what is the next line of
FNAC, MRI, MRCP, MRI and MRCP can be done.
Yeah, and after that, for any
After
pancreatic lesions, what is the going standard now?
Ultrasound guided FNAs,
What ultrasound?
endoscopic guided.
EUS and EUS FNAC bulb biopsy. So that is the next line of if you are doubtful of any pancreatic lesion, you should actually go for a endoscopic ultrasound and FNAC. This actually might be turned out to be a chronic inflammatory mass, not a malignancy. So you should always look for, and you should actually understand that chronic inflammatory mass can also mimic a malignancy. Okay. So there are some points, so that comes to this. You have actually done it beautifully. So you have actually reached the diagnosis in all the cases. So very good. So these are some of the things that I actually want to specify. So all this, the first case actually we have seen a SPEN. So cystic NET is a DD of SPEN. So this is how you should differentiate. SPEN always occurs less than 30 years. So I have shown you 2 SPEN cases. All are 27, 28-year-old females. That is some point characteristic of SPEN. Cystic NET will always come under middle age because that is the most common DD. And in MRI, it will be bright on T1 because SPEN usually have hemorrhage. And cystic NET will be hypo. Both will be T2 hyper. So that is not a differentiating point. This is a T. You should look for the T1. And SPEN, the enhancement will be similar to the pancreatic parenchyma. It enhances well, but it will be similar to parenchyma. While cystic NET, the enhancement will be more intense. And usually SPEN will be very large presentation. And NET, you know, different. And this is one slide I want all of you to see. Differentiating ductal adenocarcinoma, PNET, and lymphoma. So these are the differentiating points. Ductal adenocarcinoma will be scirrhous type. So T2 hypo. PNET will be very bright on T2. Lymphoma will be intermediate. I showed you. And ductal adenocarcinoma will be hypovascular. This will be hypovascular. But in our case, it was hypo because it was an NEC. It's a neuroendocrine carcinoma. Typical PNETs will be hypovascular. It stands out in the arterial phase. And lymphoma will be just like we have seen in our case. It is faint enhancement. homogeneous enhancement. So heterogeneous enhancement, you know the typical appearance of a ductal adenocarcinoma, heterogeneous, hypervascular. It will be hypodense in all the phases. And sometimes the entities, large entities, rim enhancement is very common because it undergoes cystic degeneration. Calcification common in peanut. It is not seen in lymphoma, only 2%. Vascular involvement, we have already discussed, without narrowing vascular encasement lymphoma. Encasement with infiltration ductal adenocarcinoma. In any seeds, vascular infiltration with thrombus can occur. And ductal involvement, again, if you see ductal involvement, first DD is ductal adenocarcinoma, and it's again very common. And in our case, we have seen that the patient with lymphoma had CBD dilatation, but no MPD dilatation. That is one point that actually helps in the diagnosis of lymphoma. And necrosis cystic degeneration, common in peanut, and this is less common in other cases. And if you see a bulky lymph node below the level of renal vein, again think of lymphoma. And this is how we differentiate a serous, mucinous, and IPMN. Serous, older women, this you know, we always discuss this, microcystic, macrocystic. This is lobulated. This is mucinous is smooth. This is sort of a pleomorphic club finger-like shape. And this all, you know, central calcification with stellate scar characteristic of serous, peripheral calcification in mucinous. And communication, if you see, then your diagnosis is branch duct IPMN. Here there is no communication. Serous cystadenomas can cause compression of the MPD. So you can see actually proximal dilatation of the CBD. And if you see diffuse pancreatic ductal dilatation, and if you see a cystic, there is more chance that it is an IPMN. Why? You see a diffuse MPD dilatation in IPMN? Because of
Mucin
yes,
mucin
very good, very good. So that's why you see that. And this is a simplified management algorithm. These are the worrisome features we have discussed. So go through this. If you are suspecting a high risk, that is enhanced neuronodal 5 mm, MPD more than 10, go for surgical resection. If worrisome features, go for US bar FNA, because all pancreatic lesions, the gold standard now is US bar FNA. And if you are seeing just a cyst with less than 3 centimeters, no solid component, no MPD involvement, just go for surveillance. So I thank all my colleagues in GG Hospital and Andhra Hospital, especially the surgical gastro team led by Dr. AML and the medical gastro team led by Narendra sir, and both in GG and Andhra Hospital. That's why like we're getting such sort of all bucked up cases in our hospital. So thank you so much. Hope it was useful. And all the PGs, I think they have actually brilliant. They have actually come to the diagnosis in all the cases. So thank you so much.
Thank you.
Yeah, Rashmi, just I want to tell one thing. Actually, it is quite marvelous from both sides now. The residents actually, they perform very well. And I think their theory part is very strong. And
Yeah,
then
the theory was very strong.
they answered almost all the
It was
questions and all.
telling.
And also they picked up the lesions now.
Yes.
And from your side, actually, you showed all the type of cases now. The entire spectrum of pancreatic lesions actually were shown, and the differentiating features and the way of presentation, and very important that is the importance of considering the age of the patient. Normally, we don't look at immediately we start looking at the image now. We start looking at the image, but the importance of looking at the age of the patient and then features, then the resectability. So I think almost all points were touched in a span of 1.5 hours. It's very good. Thank you very much. Now over to just one more thing. Just I want to ask you one thing. See whether for the biopsy, no, the last point that you discussed is biopsy, that is endoscopic ultrasound guided biopsy of pancreatic lesion versus percutaneous biopsy. So which is better?
Sir, now like all cases, we actually go for a US rather than a percutaneous.
But the thing is that from the perspective of the patient side, no, actually the endoscopic is very costly, seems.
Yeah, it's very expensive. Yes, that is one point.
Yeah.
I know,
So
sir.
even otherwise, there is no problem. Even
Sorry,
endoscopic, what I think, no, endoscopic ultrasound, when you do, anyway, you have to pierce the posterior wall of the stomach. So here actually, when you do percutaneous, only thing you have to go through the anterior wall and then posterior wall, that's all. So in a collapsed stomach, when the stomach is empty, actually, I think there is no problem. So here actually in RCC, actually we are doing all cases with the percutaneous. Nobody is doing endoscopic.
Yes,
so I think we start doing, because as far as the patients are concerned, I think there is no problem. The difficulty or the discomfort is actually the same, most probably. And also it is less time consuming though. Percutaneous, it will take only hardly 5 minutes.
Correct.
Endoscopic, the procedures, then all sorts of problems are there. This thing, the preparation, then main thing, cost.
Yes. Yes.
Okay, thank you very much. Thank you very much. Now over to
Yes.
Dr. Surimal for the
Yes, sir.
vote of thanks.
Yes, sir. Rishmi, thank you. It was as sir said, it was a marvelous session. And you have covered almost all the pathologies of pancreas, though it was 1.5 hours. As sir was telling, and PGs also have performed well. They are just for your information, they have all passed final theory examination, waiting for the practicals. So it was a very it was a good experience for them. They were actually tensed and waiting for this session. And as we told, it was focused on pancreas, they could prepare well also. So hope all the other residents made use of it. Thank you so much. Venobal sir, thank you for patiently listening throughout the session and commenting on the difference between the biopsies, percutaneous and endoscopic. Gomadi ma'am, I think she has said she came for the open remarks. Thank you, MedPiper team, and all those who are watching. Thank you. We'll wait for the next system.
The question in the Q&A session, please explain significance of teardrop sign by Dr. Nitesh. Yeah, that is just one of the signs which helps in the infiltration of the superior mesenteric vein. Actually, we describe this in the infiltration of the vein. So if you are infiltrating and you see it is just like pulled towards one side, that's why you see the teardrop sign. So that's again one sign that tells that it is infiltration. So again, you have to see the involvement, the arc of contact with the vein. That is the most important thing. And then secondary, you look for these signs. So that's it. I think there are no other queries.
Thank you, IRIA team. Ramesh Senoy sir,